So the concept of FFR-guided revasc is based on well-structured and consistent RCT-derived evidence and clinical outcome data. What about post-PCI FFR? I've drawn this just to take a snapshot. If you look at FFR, this is from the bare metal era. After stent deployment, you see the difference in the restenosis rate at 6 months after a bare metal stent when the post-PCI FFR was 7.5 to 8 and when it was more than 0.96. So that means there is more to restenosis than just tissue growing in. And the post-PCI FFR is a powerful tool to predict what we've done with our PCI. 10 years later, 15 years later, this was again shown in quartiles where the post-PCI derived FFR actually stratified patients into the risk of restenosis occurring in various one of these quartiles. And the same thing was shown in a huge meta-analysis of more than 5,000 patients, where the lower post-PCI FFR significantly increased the risk of target vessel failure, including cardiac death and MI. And these associations were consistent regardless of age, gender, hypertension, diabetes, and clinical diagnosis. That means they actually stratified them even for atheroma volume, which is a very, very powerful prognostic marker. So we know post-PCI physiology is related to outcomes. But can it be used to optimize result? So this was a study called PROPHET, in which they looked at 1,300 patients and divided them into 3 groups. One group who was controlled, they had negative FFR and the PCI was deferred. The second group had at least one lesion and the third group also the same. One group underwent angio-guided PCI and the second group, group 2, which was 180 patients, underwent PCI and then a post-PCI assessment that was guided by the FFR. Now what did they find? In the group 2, post-PCI improvement in FFR post-PCI, because they measured the FFR earlier as well, in up to 12% they required further optimization based on this post-PCI FFR, which showed that this value was not significant, so they had to go back in and do some more. And what did they find when they did that? There was a significant difference in the 2 groups. Just because of this 12% of additional work, when the post-PCI FFR was not okay, the target vessel revascularization was significantly reduced. The FFR-guided group versus the angio-guided group, 5% versus 11.2%. And if you saw the control group, their event rate was 8.2%. That means post-PCI FFR-related optimization group had fewer events than the patients who had deferred PCI. Right? And patients who did not have a physiology measured and were just left on angiography based had twice the risk of events occurring. What about some examples? I'm going to go fast so that we can stick to time and we can hear Dr. Harikrishnan, Professor Harikrishnan speak. Post-PCI FFR, we have spoken about either you can look at the main vessel or you can just look at the side branch. In the main vessel, assessment of tendon lesions and diffuse disease has been spoken of. Assessment of residual ischemia, and have we done a good job in the vessel that we have stented? In the side branch, do we have residual ischemia in the side branch? These are the basic questions which can be answered by a post-PCI FFR. This is one patient who was 62-year-old, came with a non-QMI in the anterior wall, and you can see that he's got some intermediate lesion in the OM2 as well, but the LAD was the infarct-related vessel. He underwent a stenting to the LAD. I'm not going to look at that at all, post-dilated. Now, we brought him back to the table after 14 days because he was part of a trial that we were seeing in which we had a hypothesis that we were undersizing the stent at the time of the initial ACS, and we wanted to see whether we need to optimize this later. We brought him back and we did an FFR to this OM inferior division, which was negative, FFR and RFR to this OM. We said, okay, we've got a wire, let's float it down the LAD. And the LAD RFR was positive. Since it was post-MI, we used RFR and not FFR, and it was 8, 9. And the step-up was just where the edge of the stent was. So we then did an OCT to this LAD, and I'll try and run it faster. So we let it run, and you see what happens when we come to the edge of the stent. Sorry for the suspense. That's it. And everybody in the room will see that dissection at the distal edge of the stent. Right? This is what it looks like. There's a circumferential dissection in the distal LAD, and the FFR wire has picked up this dissection. This was our landing zone measurement. We went ahead and then put in a second stent and then did an RFR, and our 8.9 has now gone to 9.7. Just a small 12 millimeter stent that covered that dissection. This is the FFR. Now that we had the wire down, we did the FFR as well, and this was 9.2, which was fantastic for a distal LAD, and we did a pullback, which was good. This is the second OCT, which we'll leave it alone. This is a 78-year-old female, non-diabetic, hypertensive, with angina with minimal effort. She was very, very frail, and both the surgeon and she ran, in the opposite direction. This is her angiogram. I'm going to just allow it to play out. So you can see that the RCA was retrograde, so we fixed the RCA at one go, but this is heavily calcified and very, very complex. Unfortunately, she didn't have money for imaging, but we did have the ability to do physiology. So what did we do then? This is what her setup shots were like. So to cut a long story short, we did a rota to the LAD and the circumflex, and then did a rota cut rather, and we'll quickly pass through all the steps. This is what we ended up with. And we did an FFR and the RFR to the LAD. This is what the FFR and RFR were for the LAD, along with a pullback, and you can see that there's not much difference here. This is the circumflex. The RFR was 1, and the FFR was 0.97. Now, even without imaging, if you get these kind of figures, you can rest assured that you've done an excellent job, and you can leave it alone. What about tandem lesions? This is a lady who had an obvious 90% stenosis in the mid-LAD. You can see on the angiogram, you can't leave this in a patient who's got angina. So he said, all right, we'll fix this. There's another intermediate lesion in the osteo LAD, and the bet in the room was that this is going to be negative. So we thought we'll do a provisional strategy for the mid-LAD and then reevaluate, and that's what we did. The LAD was stented with a pot-kiss spot, which looks perfectly acceptable, but this was the RFR, right? So then we went ahead and did a pullback, and you see that the step up is right at the osteo LAD. And it's a huge step up. It's a massive step up, and it's pretty focal, right? So we said, okay, she's got osteo LAD disease. Now we'll do an LM-LAD with a provisional strategy and remeasure the physiology. That's what we did. LM-LAD stent, pot-kiss spot, which is our favored strategy as part of our study. And this is the RFR at the end, which is absolutely negative now, and there's no pullback. This is the post-PCI FFR, which is good. That's our final angiogram, which looks perfectly good. What about FFR in the side branch? The 72-year-old lady with class 3 effort angina. Just let the angiogram play out, and you can see that she's got disease in the ostial proximal LAD as well as the distal left main. So she underwent a cutting balloon-based predilatation of the LAD, LM-LAD crossover, and then a pot. And this is what her circumflex looked like. Now we all know this might be cranial shift, this might be this shift, that shift. Now, if imaging is not available, what do you do? We did an RFR into the LCX and a pullback, and you see high gradient at the ostial circumflex. But still, there wasn't much disease at the beginning. We just did pot, kiss, and a repot, no stent. This is our post pot kit, pot, RFR, and pullback in the LCX. And that's the LAD. Both are fine. That's our final angiogram, and we just left her with that one stent, which we opened the struct. And this is what is proposed actually. If you do a post-PCI physiology assessment, if you've got optimal results, your procedure is ended. If not, you do a pullback. If you've got an instant focal pressure loss, you have proximal and distal focal pressure loss, you have diffuse pressure loss. If you have diffuse, you go for medical therapy. But if you have a focal rise, either within the stent or without, you must assess with imaging and figure out where the problem is and then fix it. Optimize it, reassess with physiology. If the anomaly is corrected, fine. If the anomaly is not correct, then you have to try and get to the place where you can safely end the procedure. That is when physiology comes in, imaging comes in. We actually feel, because you have got safety outcomes with imaging, but you have got efficacy outcomes with physiology. It's physiology that's going to tell you whether you have left residual ischemia or not. Safety outcomes are what areas you get on your imaging, and this is where we propose that you should actually use imaging. State-of-the-art PCI in 2025 is abolish ischemia. Pre-PCI physiology we have spoken of. Post-PCI has prognostic implications, is used to optimize results. In future, we are still not there, but we could possibly simulate PCI and predict results. But as has been shown in serial, there's absolutely no reliability for tandem lesions with either technique. Thank you very much.